Hello, everyone. Welcome to the Cancer Doctor podcast. I am your host, Robert Carrillo. And today, our guest is Dr. Linda Isaacs. She's a medical doctor and a graduate from Vanderbilt University School of Medicine, and she is certified by the American Board of Internal Medicine. She offers individualized nutritional protocols for patients with cancer and other illnesses in Texas. She also provides other protocols for health maintenance. And today we're going to be discussing a really important topic with Dr. Isaacs, one that caught my attention in an article that she wrote many years ago, dealing with the topic of patient testimonials versus case studies and statistics. And the publication is so valuable that I decided to contact Dr. Isaacs to see if she would be willing to come on this podcast with us to discuss this topic a little bit more in depth for the benefit of patients that happen to have received a cancer diagnosis. So Dr. Isaacs, thank you so much for joining us today.
Well, thank you so much for having me. I'm really happy to see you and to be a part of this presentation.
Thank you. Thank you so much. Let's jump right into it. You're a medical doctor that is, practicing a form of medicine that falls under an umbrella of what's known as alternative care. And in the alternative care field, when it comes to cancer patients, there's a lot of publications or marketing pieces that are done online that are patient testimonials. Could you please explain to us as a medical doctor what a testimonial is through the eyes of a doctor and what its value is, and also why it may not be so valuable to you as a medical doctor?
Sure. A testimonial is the patient telling in their own words about how they feel they were helped by a particular treatment or by a particular doctor. So the patient is telling it in their own words, and so unfortunately the patient may not have a perfect understanding of what their condition was or why their outcome is or is not particularly unusual. When it comes to testimonials in the alternative space especially, you can wind up with people being very passionate about how they were helped by a particular treatment, but when you listen to the details of their case, it turns out that from a doctor's point of view that the patient may have actually been helped by their surgery or their chemotherapy before they came to do the alternative treatment. So I don't actually use testimonials, partly because state medical boards actually really frown on it because they can be misleading to patients that are watching them. Instead, what I do is write up case reports, and case reports are published in medical journals, which means that an editor at that journal is looking over the case to say, yes, this is important, or no, it doesn't really mean anything. So there's an extra set of editors, so to speak, looking at the material to be sure that what I'm putting out there is appropriate, is not misleading. Unfortunately, case reports tend to be rather dry, whereas patients talking about what they went through and how they came out and how they're doing, that's interesting. Stories are fascinating. Case reports, a little dry, but nonetheless, if you read them carefully, they are pretty interesting too.
So if I'm understanding correctly, what you've just described is a patient testimonial is an anecdotal, historical point of view from the patient's perspective, right? But it's lacking some of the critical criteria about what might have influenced their outcome. Is that what I'm hearing?
Yeah, that's a fair way to say it because, from the patient's point of view, they're very convinced that whatever they're testifying about helped them. But a doctor may or may not see it the same way. So that's one of the variables with it. And also, a case report gives all the technical details that would help another doctor say, okay, this is interesting, this is significant. Now the phrase anecdote, that's a little tricky because some Orthodox physicians will dismiss case reports and testimonials as anecdotes. In other words, it's a one-off. It doesn't mean that everybody does well. And there's some validity to that as well, but at least with a case report, you know for sure that the outcome is unusual.
Okay, you just mentioned something very important, unusual, that in a case report, you're looking for something unusual. Can you please define what you mean by that unusual?
Well, what I mean by a good case report and having an unusual outcome is that they have an outcome that you would not expect. There are several components of a good case report, and you mentioned earlier I've actually written an article talking about this very issue. And the same criteria would also apply to a testimonial to say which is good and which is not. So the first thing is that the person needs to have had a very clear diagnosis. So what that would mean is that, for instance, a patient might say, I had a mammogram, it was terrible, they told me I definitely had cancer, I never got a biopsy, I never got surgery, and I'm still alive 20 years later. That can sound impressive to another patient.
Mm-hmm.
To a doctor, it does not, because even the worst reading on a mammogram only goes along with cancer somewhere between 80 and 95% of the time. So what that means is if you take 100 women and do a mammogram and it looks really bad, nonetheless, when you do the diagnostic procedure, the biopsy, 5 to 15 of them do not have cancer. And so that person who is giving that passionate testimonial about their horrible mammogram and what the doctor said to them when they refused surgery, none of that really holds water from a doctor's point of view. So the diagnosis needs to be very, very clear, and that's step number one.
Okay. One of the things that you just mentioned in the example of a woman receiving a mammogram, that there's going to be some false positives in there based upon the data that we currently have. So if she doesn't do anything else and she's alive 20 years later, what you're saying is maybe she never truly had cancer in her breast.
That's right. She may have
Wow.
never truly had cancer. And so her survival is questionable. We don't know whether what she did to, presumably change her diet or, whatever it was that she's testifying about, we don't
Mm-hmm.
know for sure that that cured her cancer because we don't know for sure if she had cancer in the first place.
Wow. Okay, that's very valuable. Now, in the case studies, you've mentioned that there's obviously a difference between a case study and a patient testimonial, but yet there are doctors that would view both as being anecdotal, right?
Yeah.
But in your professional opinion, give me some of the greatest, some of the best value out of a case report or a case study that you're compiling and putting together about a patient. What are some more of the features that has? You mentioned a clear diagnosis, and I understand that, but we were talking about results with a patient that were out of the ordinary, really. It's not normative in this case. Can you give me a little bit more perspective on that? Can you break that down for us?
Yeah, sure. So the next step after confirming that the diagnosis is correct in this story would be to say, is the patient's outcome unusual? And so here we get into needing to know what the usual outcome is.
Mm-hmm.
Just to pick another example, you have it sounds like I'm picking on women here, but breast cancer is an easy one to talk about. You have a woman who had breast cancer. It was biopsied, the lesion was removed, she had some lymph nodes taken out, and unfortunately, 5 of them were positive. And so she goes to see the oncologist, and sometimes oncologists will say very strong things under these circumstances. And I've actually had patients tell me, my doctor said, if I don't get chemo, it's like committing suicide, which is a little bonkers because what the chemotherapy is doing is improving the odds, but it's not a guarantee that the cancer won't recur down the road. But nonetheless, if that patient then refuses the chemotherapy and is doing fabulous 10 years later, it really it may not really mean all that much because a certain number of people are cured by the surgery alone.
Mm.
So that's where, again, you need a bit more information to know for sure whether that's a meaningful outcome. And so the most convincing case reports are people like, a gentleman that I have in my own practice. And in fact, his wife called the office today looking for some routine paperwork, basically. But he was diagnosed with colon cancer and it had spread to his liver and to his lung. And he actually had the liver tumor surgically removed. I talk about him in some of my lectures. But the lung tumor remained, and on this protocol, it gradually went away. And that is a remarkable outcome. So he is now 9 years, 8 or 9 years out from his diagnosis of metastatic colon cancer, and the lesion has gone away. So that is a remarkable case report. I have other people where the lesions don't go away, but they live way longer than they should have. And here I'm talking about a multiple of 3 times as long as you would expect, 5 times as long as you expect. Or, in the case of one of my patients with pancreatic cancer, she lived 20 years with a diagnosis that usually would kill in 20 months or even 20 weeks. So that's the kind of dramatic improvement that makes a case report be something that I could show to another doctor and they'd say, that's remarkable.
Okay. That makes sense. And if I could summarize that, in other words, we have, you brought up this patient of yours with colon spread to the liver and lung. So stage 4 gets on a particular protocol that you put him on. He's still alive 9 years later in a condition that, generally speaking, would have taken out everybody else by now. And this is what makes it unusual. Is that correct?
Exactly.
Okay.
Yes. So shrinkage or resolution of tumors, prolonged life, either one of those is remarkable. And so what you have to look at there is you have to know what remarkable is in effect. And that can be tough for a layperson because you don't know medicine to know that the usual outcome for somebody like him is very short. Now, when I write up a case report and submit it to a journal, what I do is find things in the medical literature that will say what the typical life expectancy is for somebody like my patient. So it will be in there. Now, your testimonial, your person just speaking about their situation, they're not too likely to be able to do that. But nonetheless, you can get a feeling. I mean, there are some people out there giving testimonials that I would agree their case is remarkable. But there's other ones that, not so much. I'm not saying that I don't believe these people. They absolutely are sincere in what they're saying, and they may have been helped. They just can't prove it. And I, as a physician, am not going to post information on my website that isn't solid, that isn't really definitely showing that my protocol had a positive outcome. And I can think of multiple patients off the top of my head that are in my practice that I think their outcome is really remarkable. Their oncologist gave them all sorts of gloomy predictions about what was going to happen to them. But when I go to the medical literature, I can't prove it. And so I'm not going to write those people up and put them on my website. It's not fair to the patients.
Yeah. I totally respect what you're communicating right now because it's very admirable. First of all, that you don't want to post anything like that would mislead a patient. And I want to touch on something between the two stories that you provided. The one, your patient with the colon cancer who's 9 years out, and then a woman that had metastatic cancer, but there was a false positive in the diagnosis. She never had chemo. She's still alive, but that's not unusual because she never had the cancer in the first place. Possibly, right? We don't know because there was not a biopsy, correct?
Well, if there's no biopsy, then there's no definite cancer diagnosis.
Okay.
So under those circumstances, you really shouldn't be
You
airing the
could,
story.
right. And even if in the case of the breast cancer patient, she was diagnosed with a biopsy, we have a definitive cancer, has a surgery to remove the mass, there's still a certain percentage of the population that's going to be just fine without the chemotherapy. And
It
there's
de-
nothing unusual about that.
uh, it all comes down to how many nodes are involved, and it does start to get into a more technical issue.
Okay.
And in some of the case report collections that Dr. Gonzalez and I did, we did include one patient of mine who had, if I remember correctly, she had somewhere in the neighborhood of 19 positive lymph nodes.
Hmm.
And she had chemotherapy, and she wound up with brain fog and felt terrible and all the rest of it. But she'd also been told that it was pretty unlikely that that was going to cure her. And she then, her doctor thought she went on tamoxifen, but she never actually took it. And
Hmm.
she wound up. She told me the brain fog and all that improved, and she was feeling really quite well. And she told me that every time she went in to see the oncologist, he would call in all his colleagues to come and see her and see how good she was looking with the chemo plus the tamoxifen he thought she was taking. He described her as a miracle. So we went ahead and used her because her prognosis was really quite grim with like 19 positive nodes or whatever it was. But it's a gradation. I have a number of patients in my practice that have one or two positive nodes, and that is a very gray area. Some of those folks would probably be fine regardless of what they did.
What you're discussing now is a great deal of context, patient context, what they're doing, right, and not doing. Let's talk about that for a moment as it relates to even a case report or the things we don't know about the patient testimonial. What are some of the variables that the patient may or may not be doing that could influence the outcome of their case?
Well, I think the biggest one is, are they actually doing the program that was advised? Not everybody actually follows through. And I don't mean, again, to be critical or sound negative about it, but the reality is that we live in a world where we're bombarded with constant stimuli to eat stuff that we shouldn't eat. It's endless. While you're sitting watching the news, you've got pictures of beautiful pizzas dripping oil and cheese, and it looks fabulous, and you shouldn't eat it. And people live with other people, and those people bring in food that they shouldn't eat. And also, food, yeah, comfort food is called comfort food for a reason. It lifts the mood. And sometimes patients who are dealing with this kind of life-threatening issue are, they have their down moments when they say, you know what, I don't know if I'm going to make it or not. I just need to eat a piece of chocolate cake right now. But if they do that all the time, then a protocol like this is not going to work. That's probably the biggest issue on a day-to-day basis.
Okay. Yeah, you've mentioned your protocol, and I know yours is a nutritional supplemental type protocol, also incorporates coffee enemas in it and all. And you're really discussing, whether or not the patient is going to follow the doctor's orders, compliance, right? And it's
Yeah.
really difficult, right? Especially when it comes to something like diet. When I take what you're saying right now and I apply it to a patient testimonial where we know very little, few details, right? The
Mm.
nitty gritty. So there may be a positive testimonial, and it's true. I mean, nobody's questioning the authenticity of the testimonial or how radical the outcome might have been. But what we don't know about that patient is all the lifestyle changes they might have made in the process, including just their day-to-day diet. Is that fair?
That is definitely fair. And, I would also say that in many cases, when patients have an extraordinarily good outcome with standard therapy, like chemotherapy or especially immunotherapy, I believe that there are times that the reason why that patient is doing so well is because they were not only doing the orthodox treatment, they were also doing a lot of nutritional work. So that the combination can be very, very beneficial. But the doctors writing up the case report about the amazing result with immunotherapy, or for that matter, the amazing spontaneous remission, they don't ask the questions. And I can't tell you how many, well, even that case that I just spoke about, the gentleman with colon cancer, his oncologist sat down and said, you know, every oncologist has got one or two people like you in their practice where they get better and we just don't know why. And the reason he doesn't know why is because he didn't ask,
Okay,
you know?
that begs the next question, Dr. Isaacs. Why don't they ask? Why?
Part of it, honestly, I have a lot of compassion for oncologists. I don't know how they do it. I really don't. It's a tough lifestyle. They, especially in the world of corporate America taking over medical practices, which they are, they're expected to crank through patients, see them very rapidly. They don't have time to think. They're exhausted. So sometimes they just don't. They don't think outside the box. I have had a few patients that somebody did come in and sit down and say, can you tell me a little bit more about that diet? It has happened. But most of the time, the doctors, they're just too busy. And then you throw in that they're only seeing one patient like this. If they were actually, many years ago, Dr. Gonzalez had my longtime colleague, Dr. Nicholas Gonzalez, wound up having an oncologist come and sit in with him for several months. And the oncologist actually walked away convinced that there was something worth following up in what we were doing. But that's because he saw multiple cases. You only see one. And bear in mind that the implication out of all of this is that that poor oncologist has spent all this time and all this money and all this training, and he's getting mediocre results. And meanwhile, here's this crazy alternative cancer program with supplements and coffee enemas doing a better job than he does. That's a big jump intellectually for them to take. So they'd really rather just sort of pretend that it didn't happen.
I understand. Yeah, it's just. Yeah, I think it's important to understand that medical doctors are human beings too, just like everyone else. And they have a life to live and a conscience as well they have to deal with on a day-to-day basis like anyone else. I do have a question regarding what we just discussed regarding why doctors don't ask the questions of their patients, what they might be doing. You've put together case studies on individual patients, and you mentioned your late colleague, Dr. Nicholas Gonzalez, as well. These case studies, so these are case studies that you've initiated on your own, where you're gathering the data and following the patient for a period of time. Is that how this works for you as a physician?
Yes, the case reports are all patients who saw either myself or Dr. Gonzalez, and we would follow them over a course of years. And what I typically look for as I'm following a patient, when I first see them, I'm thinking to myself, is this patient potentially going to be a case report or not? Now, not all of my patients fit into that category. As an example, like I was mentioning, I can think of some folks off the top of my head, like a patient with ovarian cancer, and she had surgery. The surgery, the odds are that it did not cure her, but it might have. Her oncologist said all kinds of gloomy things, but she never got chemo after the surgery. She's been with me for 3 or 4 years. She's doing great, but I can't prove that she had cancer when she started with me, for sure.
Okay.
So, but I'm happy that she's healthy.
Right,
So it's not like there's no meaning in all of this. It's
right,
wonderful. I'm happy for her, but I can't
right.
write her up as a case report.
Because it falls short of that being unusual.
Exactly. It falls short of being unusual.
Okay, that makes sense. Now, so I want anybody watching this to appreciate what's involved with a case report as far as time. If you decide you have a patient that This patient really qualifies as someone unusual. I want to do a case report. How much additional time is that, putting on your responsibilities to be following around a patient? I mean, as I from the outside looking in, I'm thinking, wow, that's a lot more additional work if I'm going to get really deep in the weeds with the patient's life to find out what's going on with them.
Well, I can't say that it's not like I'm calling them up and doing an elaborate interview to interrogate exactly what they've been doing. It's more that I already asked them a lot of questions and know whether or not they're doing their program, and they've been following up with me. So I'm not looking for anything. I certainly assume that if they'd gone off and were doing something else in addition, that they would tell me about it.
Hmm.
And so I don't know that that's really all that big a time commitment. It's more just the time that it takes to go through the chart, to methodically write it up, to create a document that somebody else can read, and to find the medical literature that supports my belief that their outcome is unusual. Then it's submitting it to a journal and waiting for the journal to get back to me, and et cetera, et cetera. So it's a process, but it's not impossible.
Okay. So that leads to another question just based upon what you just mentioned. When you meet with your patients, just in general, how much time are you spending with the patient one-on-one when they come to meet with you?
Yeah, this is a low volume practice, and it always has been, because Dr. Gonzalez, when he was still with us, and I spend a lot of time with the patient. The first session is really just me getting information from the patient, and I typically spend an hour and a half, and then there's some time thinking about the case, and then meeting with them again to explain what needs to be done. So that would include going over the diet, going over the various detoxification routines, going over the supplements, going over some test results. And really, what I'm trying to do is educate, because if somebody understands why they're doing something, they're much more likely to do it. So my website, follow-up emails that I send, the time that I spend with people, all of that is trying to for screening before they come in, for that matter, all of that is trying to be sure that the people that come in are likely to follow through.
Okay. Okay. So for your patients in particular, there's a screening process before they come in. They get through that screening process, which means they're a candidate and someone that's the best of your ability, highly likely going to follow through with the protocol, which is they're going to be compliant. They come and they meet with you for 90 minutes. You're going to spend some time thinking about this particular case, putting together the protocol, then training them, educate them on what to do and how to do it. Once they go home and they begin this, do they come back to you in person for follow-up meetings at particular points in time? And if so, how long are those meetings? Or is it by phone or Zoom or
Um,
Skype?
well, typically I follow up with them by phone. I mean, they're always welcome to call me. And, Dr. Gonzalez and I batted back and forth about how to structure all of this in terms of payment, and finally just decided that the best way to do it was, an upfront charge that will also make it so people can go ahead and call whenever they have a need.
Okay.
Because the last thing I want is for somebody to, be sitting there saying, oh, I probably should call, but I don't want to get charged $150 if I do.
Mhm.
I
Mhm.
don't want them to be thinking like that.
Mhm. Mhm.
So I want people to call me if they have a question or a problem. In terms of in-person follow-up, it really varies. Like that gentleman with colon cancer that I just talked about, I haven't seen him in person in years. He's just plugging along with his protocol. So, it varies from person to person.
Okay. Yeah, and I'm asking those questions because my mind is thinking about these case reports that you've written, and when you identify, oh, this person's unusual, right? But obviously, after you've spent that initial bulk amount of time kicking off this relationship, and they go home and they start doing well, and there's follow-up telephone calls, and maybe they need to place an order for something or ask you a question. It's through that process that if their case is unusual, it's just going to emerge quite naturally that, oh, this patient is getting my attention here,
That's
because
right.
what is taking place is, I call it extraordinary. It's kind of going outside the boundaries, right, of what should normally take place with this type of patient.
That's
Is that,
right.
is that fair? Fair to say?
Yeah, that's exactly the way that I look at it, is that those extraordinary cases are going to call themselves to my attention just in the course of my doing my usual work.
Okay. Okay.
Yeah.
You,
And
you,
I'll also just throw in, I mentioned in spontaneous remissions kind of in passing, but that's,
hmm,
something where a doctor will write up a case of spontaneous regression or spontaneous remission because they had a patient who had cancer. It's usually about cancer, and that patient's disease magically went away for no reason that the doctor can understand. And so, sometimes people will say, well, all of these case reports that I'm writing up, that Dr. Gonzalez wrote up, which if you include the ones about our predecessor, Dr. Kelly, we're starting to get into like 200 case reports easily. And so, people can say, well, all of those are just spontaneous remissions. But there were
mhm.
some doctors there was a doctor that actually studied spontaneous remission and went through the literature trying to estimate how common is this. And for metastatic disease, and bear in mind that I'm saying that patients need to have clear-cut active cancer when they walk in the door for this, to be a good case report. For metastatic disease, spontaneous remissions are somewhere in the territory of 1 to 60,000 cases to 1 in 100,000 cases. They're not very common. And what the investigator said after reviewing the literature and looking for how often this really happened, they said that the likelihood of any individual physician seeing more than 3 cases of spontaneous remission in their lifetime was so low as to be statistically impossible. So, in other words, your odds are probably better buying a lottery ticket than to see that.
Well,
And yet, I have more than that myself. And that's why I keep doing what I do. Because I've seen people that should be dead that are alive, and there's enough of them that regardless of, how crazy some of my med school friends think I am, I still believe there's something here and that something needs to be followed up on and made available.
so a couple of points I want to make. When you were talking about these spontaneous remissions or regressions, and legitimate, and you cited a professional that said doctor's going to see maybe one in 60,000 or 100,000 patients that are going to have a spontaneous remission. I mean, it's so rare, right?
Mhm.
And what I'm really hearing when you communicate that is that if a spontaneous remission happens, it's so rare that really what we're dealing with now is a miracle for for the patient. I mean, it's kind of supernatural. It goes out of what's natural or even extraordinary. It's so way out there. It just kind of disappeared. Is that really what we're saying?
Well, that's what the doctors writing up the cases are saying.
Hmm.
I must admit that in many cases, I look at those and wonder, like, what was the patient doing that they didn't tell the doctor about? And an example of that, now this is all, hearsay, so to speak, but supposedly Dr. Kelly, our predecessor in this work, told Dr. Gonzalez when he was doing his research that there's a series of cases of spontaneous remission of a particular type of lymphoma. And that paper was written by a doctor in the 1970s. And that Dr. Kelly happened to know that all the patients that guy was writing about were his patients, that they were people that had seen Dr. Kelly, their disease went away, and the oncologist decided they were spontaneous remissions. But if you ask the patient, there's nothing spontaneous about that remission. It involves swallowing a lot of pills.
Hmm.
So I think that, that's the other wild card in all of this, is that the doctors, they've had it so fixed in their head up until quite recently that diet doesn't matter, that the concept that changing the diet can affect the disease it just doesn't register.
So that's so fascinating to me. Only because I think that it matters what kind of gasoline you put in your car. You don't put diesel in unleaded and vice versa. But that, yeah, okay. Everything that you're touching on is just bringing me back to this, to the topic that we started off with on, the case study versus a testimonial. You're mentioning so many variables, like even in the case of Dr. Kelly with these case studies that were, well, they were written off as, oh, this is a spontaneous remission, but the reality was it wasn't. These patients were doing something and they received some extraordinary results that were really unusual, which qualifies them for a case study. But those are exactly the ingredients that we're missing in a patient testimonial that we might see on the internet, correct?
Perhaps,
Okay.
and I don't, it would take a lot of my time to be evaluating all these testimonials. And
Sure.
actually, a patient asked me to do so just the other day, and I explained, I mean, I read really fast. A video is really slow. I can't spend the time to
Mhm.
analyze every testimonial out there.
Mhm.
But what you want, if you're truly going to analyze a situation, is to say, you know, what was the diagnosis? Is it clear? What did they do? Is it unusual? Those are your three questions right there.
Okay. Were they diagnosed? What did they do? Was the outcome unusual?
Exactly. Hmm.
Okay. Okay. All right. Now, along those lines, then, and really that, what I'm, those 3 points that you just made about a testimonial, that's how a patient should really determine if this is really persuasive or not.
Right.
Okay.
That's right. And, bear in mind, I feel for the patients because, many times they've been given a diagnosis that there really isn't an effective treatment in the Orthodox world for it. And they would love to have somebody hold up a sign and say, this is where you should go. But the reality is that isn't typically possible. I can't do that either. I can't talk people into this or, show them case reports and tell them, oh, this you're going to be just like this.
Mm-hmm,
All I
mm-hmm.
can say is, here's what's possible, but do I know if it's going to work for you? I really don't know. I won't know until we try. And if in the meantime something else makes more sense to you, that's what you should do. Because the attitude and the belief structure of the patient is so important.
So, again, a couple more questions just based on what you said. You
Mm.
mentioned these case reports are unusual. They're not a guarantee that your results will be exactly the same for your condition, though you may have the same diagnosis as this person in the case report. But there's a possibility. But it's not a probability. Is that fair?
Um, that one's impossible to answer, to be
Okay.
honest, and
Okay.
it's a little medical legally tricky for me to even try.
Okay.
You
No, that's
know,
fair.
yeah.
Yeah, that's perfectly fair. Yeah, because I know there's all kinds of variables with, from patient to patient. They're not all the same. You mentioned in your article on evaluating antidotes and case reports that when you're putting together a case report, it's important to challenge, de-challenge, and re-challenge. Can you explain that and why that's important when you're putting together a case report or
No,
determining
that's
what's covered?
that's an example of a case report that could be more convincing on a particular topic, and it's more applicable to drug reactions. In other words, I take a drug, I break out in a terrible rash. I stop the drug, the rash goes away. I take the drug, I break out in a terrible rash. At the end of that sequence, you can say, the rash did it, and you don't need to check with 1,000 other people to see if they got a rash.
Mm,
I got a rash and it was definitely caused by the drug.
mm, okay.
The case that the case that I mentioned in regards to something similar was a woman who saw Dr. Gonzalez and she went on the program and her metastatic breast cancer resolved. So what did she do? She stopped the program and it recurred, and then she started it again and it resolved. So that is not a course of action that I would recommend anybody do. But nonetheless, it does, from our point of view, illustrate that for that particular person, the protocol was effective because it worked when she did it. When she didn't do it, it stopped working. And when she started again, it started working again.
That's very compelling right there, right? Obviously, if I was a patient and I heard that story, I'd go, "Wow." Well, obviously, it's the protocol, right? And this, and it really sounds like the protocol, in this case, a nutritional supplemental with coffee enema kind of protocol. It it's really a way to maintain the disease at bay. Is that what I'm hearing? I mean, that's it's managing it really well, and it's keeping it in check, and therefore don't stop doing this.
And that's certainly what I would say. And patients, I have patients that are still swallowing lots of enzymes, 20 years down the road, and I have some patients who stop after, 7 or 10 years or something, and some of them do fine, and some of them have a recurrence. From my point of view, you wouldn't develop cancer in the first place if there wasn't something wrong with the mechanisms that keep cancer at bay. Because I believe that we're all creating cancer cells all the time, but we're also getting rid of cancer cells all the time. And I also believe that a big part of that mechanism is pancreatic enzymes, and that's why we use them in our treatment. But that's getting way beyond the scope of what we wanted to talk about, I
Yes,
think. But
yes.
nonetheless, yeah, I believe that people should keep doing it.
So within this context of a patient testimonial that someone might see on the internet versus maybe diving into the weeds of a case study that has more data inside of it, now the patient comes to you and says, well, what are your statistics? How does this all relate? How does this tie into statistical data when the patient's wondering, like, well, what is your success results for breast cancer, Dr. Isaacs, or what are your success results with pancreatic cancer? Help us understand why that question is not the correct question to be asking.
Yeah, I totally understand why people ask it. Don't get me wrong, but it's not answerable, and I'll try to illustrate why. Suppose you wanted me to do a breakdown of the numbers on metastatic breast cancer. So let me tell you about a story. So this is a patient that I took on that I honestly thought she was probably too sick in the first place. Okay, so right there, should I include that patient or not? I took her on because she begged and pleaded that I take her on. But should I include her? I don't know. So then she goes on the protocol and she's actually pretty stable for 6 months. But then she decides to go see another practitioner, and that practitioner talked her into discontinuing the treatment and doing something else that involved something that affected her lungs, and she wound up in the intensive care unit for 6 weeks. What do you think? Should I include her or not?
No,
For
I don't.
my data. Now you might say, "Oh, I don't think you should include her." But I can tell you that from a scientific point of view, many people would say that you should include her. And because I tried to treat her, it's called an intent to treat analysis. And this was actually a big problem with the clinical trial that we did. But again, a whole big story. But you could say, well, the poor lady, she got so stressed out by taking all these supplements that she had to go look for something easier. So why shouldn't you include her? You should include her. But I don't think I should include her. But then every decision that I make about who to include and who to leave out is a form of what we call in the trade cherry picking. In other words, you only pick out the people that are doing well. And so there's all kinds of ways to play games with those statistics right up there.
Okay.
Then there's the question of, okay, who do you compare them to? Because in order to say, I got miraculous results about all my patients with metastatic breast cancer, you need a group to compare them to. And what people that are doing that kind of analysis will do is use what's called the SEER database, SEER, And that's the big database that the government creates where they lump everybody together and they say, what's the outcome for stage 4 breast cancer? Here's the problem with comparing my practice to the SEER database. The SEER database includes people that were diagnosed at the point where they were so sick that they weren't able to travel anywhere. Whereas my patients are all feeling well enough to spend the time investigating me, get on a plane, come to see me, start the program, take a lot of supplements. The SEER database, in other words, it includes a lot of people that are a whole lot sicker than the ones that got on a plane to come see me. So that is an automatic advantage to everybody that's using that as their comparison. You used to see, like maybe 10 years ago, you used to very commonly see advertisements for the big medical centers. Well, they'll say, we get results that are above average. And then somebody pointed out this little issue in a journal article in one of the big journals, and they stopped doing it, which is good, but they should have never done it in the first place, okay? So you really can't generate meaningful statistics out of one doctor's office. Another one that I've heard, a clinic will say, we get better results with stage 4 cancer than anybody else does. Well, stage 4 cancer, that can be a very, very short prognosis with, say, pancreatic cancer, but it can be a very, very long prognosis with a lot of other diseases. So to lump everybody with stage 4 into one big basket and then say you're getting better results doesn't really mean anything at all. And unfortunately for me, when I hear somebody do that, it just makes me say, wait a minute, if you had really good results, why are you saying that? Can't you talk about something that means something?
Okay.
Yeah.
Yeah, I want to recap that to make sure that I'm understanding it correctly. So when we start talking about statistics and we compare the outcomes, patient outcome, let's say in a private practice like yours compared to the SEER database, which is the government database on cancer patients that are really stage 4, late stage, poor quality of life,
Some of them
versus
are.
some of them are, okay,
Yeah.
some of them are, versus patients whose quality of life is much better. They're able to research, they're able to travel, their quality of life, they're healthier, in other words. Even if they were stage 4, they're still healthier, they're intact. And trying to pull out statistics against that SEER database seems to be a little bit disingenuous at times because of what you're comparing it to. Is that
Yeah.
fair?
Yes.
Okay.
Yes, that is fair. That's exactly the case. And so, what I believe, case reports are not, they're not going to convince your oncologist that you're making a good choice, but at the same time, they're as good as I can ethically provide. And that's what I do.
Okay. In other words, for a private practice like yours, the case report is the very best thing that you could ever hope to provide a patient by way of a meaningful outcome based on a context. It's based on some integrity, right?
That's
Um,
right.
okay, that's great. Okay, now then how does the patient, after assessing all of this, let's say a patient did look at the case study on a particular set of patients, right, that fell in line with similar to their diagnosis anyway. How would a patient determine their relative versus absolute risk about what to do? Right? They're trying to evaluate the decision. Risk, you know, what do I do,
Yeah.
doctor?
Well, that's a tough one to answer, because I mean, I've never been in their shoes, and I totally, like I said, I totally sympathize that it's a tough thing to have to choose.
Mhm.
I mean, the patients that come in to see me, though, you know, they they really just look through a lot of different things and they go with what makes sense to them.
Mm.
They like I saw somebody last week who said, that she had she had attended one of those, seminars where multiple different people are talking about various alternative approaches. And she said, there was just something that resonated, that made sense. And I'd also say, if there is a curative option in Orthodox medicine, do it. If I found a lump in my breast, I'd get it out. If you have a mass in your colon, get it out. There are times that Orthodox medicine can give you the results that you're looking for. But then when you get into that gray zone, then it starts to get into what makes sense to you. So if you read through my material and say, well, if what she does is so great, why isn't she at Sloan Kettering? Then this is not the way you should go, because you're saying you don't trust me, and you should find somebody that you do trust. I'm not here to talk people into anything.
Love it. Okay, that's fantastic. You mentioned that, hey, orthodox medicine, conventional medicine, may be curative for some patients. That's a big word, curative. Um, and I'm assuming that when you mention it, and you can correct me if I'm wrong, maybe in the case of breast cancer, you're able to remove a lump, get a lumpectomy, take it out, or if it's colon, remove this, because the published literature that exists actually supports that if you remove it, survival rates exceed 5 years or more. Is that a fair statement?
Well, you're starting to get into another gray zone, I suppose, and
Mm,
but because breast cancer can recur well after 5 years
mm,
sometimes. But
mhm, mhm.
but having said that, yeah, that's the general idea.
Okay. And again, we are speaking about in generalities because every case is unique, the patients are unique, and there's a lot of variables, right? Obviously. Um, I mean, even, we're talking about breast disease. Even among breast disease, there's different forms of breast cancer. They're not all the same. So,
Right.
okay. That's great. That's really helpful. You know, we were talking about a moment ago comparing the outcomes of a private practice like yours to, let's say, the SEER database. What are the differences between the patients that are in clinical trials right now for some new drug versus patients that are out there in the community, right, doing what they're doing? What is that all about? What do patients need to know about, oh, those cancer patients doing a clinical trial versus themselves?
Yeah, the patients that are enrolled in a clinical trial are usually healthier than people that are in the general community, partly
Mm,
because with the same diagnosis, that is. And that's partly because the same idea that they're healthy enough to investigate their options, they're healthy enough to travel to go get the treatment. So, all of those things can factor into it. But also, many times in a clinical trial, you want to minimize the variables. In other words, you don't want to take on the patient who also has serious heart disease because you want to find out if the cancer treatment works. So if they die of a heart attack while you're trying to treat their cancer, you just have a giant question mark instead of a data point. And remember that these trials are incredibly expensive to run. So they don't want to enroll patients who have issues with their liver or issues with other body parts in effect. But what that means on a practical level is for your patient in the community who has other medical problems plus the cancer, it can be a little misleading to believe that the data that the oncologist quotes you is applicable to you.
okay, that's wonderful. Is there anything regarding this topic that's of importance that we didn't cover that you would like to express?
I don't think so. I think this has been a pretty thorough discussion, but what I would also encourage people is, I have that article about case reports, which I wrote it some time ago now.
Mhm,
It's been
mhm,
8 or 9 years ago,
mhm, mhm,
but I looked it over again this morning, and I like to think that it's interpretable by a regular human being as
mhm,
opposed to a medical person.
mhm.
So I would encourage you to take a look at that. And hopefully this recording as well will have been of help.
Absolutely. I have the case report here with all my highlights, right?
Mm.
I really enjoy it. I think it's understandable. I think it's very helpful as well. Dr. Isaacs, we have a tradition with our guests that have come to us to be on the Cancer Doctor podcast, and it's to ask a question of the next guest that comes on to meet with us. And so I have a question for you that's been posed by a previous guest who remains anonymous. And so here is the question for you, Dr. Isaacs. As a medical doctor, what is giving you the greatest joy, or at least one of the most significant joys as a medical doctor?
It always makes me happy when patients take what I tell them and run with it, that they really put it into practice. And I, I've gotten really more joy from knowing what an impact it makes on their life. Like for example, just it wasn't even me that found this out. I had actually done an article for another, like a magazine, and the editors had asked me to submit some case reports. And I said, well, how about if you interview the patients? Because that way they could hear from the patients themselves, and so they interviewed that same gentleman with the colon cancer that I talked about earlier. And, what he said was that what he told them was that he was going to get to see his son grow up. And just hearing that, just knowing that a 5-year-old kid didn't have to go to his father's funeral, and that's when you suddenly see the reality of what keeping this work alive and offering it to people can accomplish. Or that woman with pancreatic cancer, that her granddaughter was born around the same time she was diagnosed, and she got to see her grow up.
It's very rewarding, very, very, very rewarding. I
Right.
appreciate that. And I thank you so much for the work that you're doing. And I'm sure that those that care about this topic and the field of study that you're in, we're going to definitely keep it alive, right? That's the goal, after all, for patients in the future. Thanks again, Dr. Isaacs, for being with us. We really do appreciate it. And we look forward to the next time that we can spend some time together.
All right. Thank you.